Hello, and welcome to the ACR Journals on Air podcast. I am your host, Vicky Shanmugam. There are some well-recognized comorbidities in autoimmune disease, and we often find ourselves pondering, what came first? Today, I am joined by a scientist who, driven by this question, embarked on a fascinating journey of discovery. The manuscript we will discuss today is What Came First? Population-based evaluation of healthcare encounters for depression and anxiety before and after inflammatory arthritis diagnosis, disentangling the relationship between mental health and arthritis. It was published in Arthritis Care and Research, and a link to the manuscript and disclosures are in our show notes from today. Our guest today, Dr. Elisa Hauran, is the lead author of the manuscript. She completed this work during her PhD at the University of British Columbia, where she also worked as a trainee at Arthritis Research Canada, and focused her work on the links between mental health and inflammatory arthritis. She's now a postdoctoral scholar at the Department of Epidemiology and Population Health at Stanford University. Welcome to the show, Elisa.
Hi, Vicky. Thank you so much for having me here today.
So as I mentioned, this work in this manuscript is a culmination of your PhD research. Take us back to the beginning of your PhD. You'd previously worked in your master's degree on gout. What prompted you to study this relationship between mental health and inflammatory arthritis?
Right. So my previous work, it did focus on gout, and I was particularly looking at using a mixed methods approach to evaluate a multidisciplinary care model for gout that involved rheumatology, dietetics, and pharmacy. And it may seem like a little bit of jump from my master's research to now my PhD research, where I focused on mental health in people with inflammatory arthritis. However, a large portion of my master's work was doing qualitative research. So I conducted one-on-one interviews with people who had participated in that pilot model of care for gout. And there was one theme that came up that was not necessarily anticipated, but it came up over and over again. And that was knowing that somebody cares. And so there were a number of participants who felt that with all of these calls with the pharmacist or the rheumatologist or the study team checking in and seeing how they were doing, they actually felt that somebody cared about how they were doing. And so in those interviews, there was almost like a sense of loneliness or not feeling that because with a rheumatic disease, often it's an invisible illness and not everybody completely understands what they're going through. And so that really stuck with me, that knowing that somebody cares. And so I took a year off to work between my master's and my PhD because I wanted to think about what I really wanted to study and, if the PhD was something I wanted to pursue. And with those findings in mind and wanting to move my research more into the area of mental health, just because I have a long-standing personal interest in this topic, I decided to bring to my supervisor the idea of looking at mental health in people living with inflammatory arthritis. And then early on, I also wanted to get some feedback from people living with arthritis. So I brought this idea and some research questions to explore with the Patient Advisory Board at Arthritis Research Canada for their feedback and input and to understand if this was a meaningful question to them that I could explore in my PhD.
That's really amazing. And it sounds like you put a lot of thought and deliberation into this topic. Can you fill us in on the background data? What was previously known about the relationship between mental disorders like depression and anxiety and inflammatory arthritis? And what was your hypothesis going into this project?
Of course. So at the outset, there was plenty of evidence to show that people with inflammatory arthritis are disproportionately affected with mental disorders. The evidence largely focused on depression. There were some studies on anxiety disorders, and a lot of the research was really in rheumatoid arthritis and systemic lupus. So at the outset, even just before starting my PhD, I worked with some PharmD students from our faculty at UBC, and we worked on a number of systematic reviews and meta-analyses to kind of synthesize those studies that had looked at the prevalence and incidence of depression and anxiety in different types of arthritis, specifically the ones that didn't have systematic reviews done before. And so through that work, we identified that the prevalence of depression was as high as 20% in psoriatic arthritis and 29% in ankylosing spondylitis, which were two of the inflammatory arthritis that I focused on in this paper. And then there were other systematic reviews that estimated the prevalence was as high as 39% for depression and rheumatoid arthritis. And this is much, much higher than what we see in the general population. And so I think through the process of also doing these systematic reviews, it really, as tedious as they are, they bring your attention to the breadth of research in a subject area. And so it brought up different papers that kind of sparked an interest in where I wanted to take my research. And so there was a paper by Dr. Mari and colleagues out of Manitoba where they used admin data to see that there was a rising incidence of depression and anxiety before the diagnosis of rheumatoid arthritis. And then I also, within those systematic reviews, found another paper by Liu and colleagues that showed that individuals with RA have an increased risk of depression, and conversely, those with depression have an increased risk of rheumatoid arthritis, or RA. And so what I kind of found interesting here was there was, evidence for this bidirectional relationship. And that sparked my interest in thinking about all the underlying biopsychosocial processes that might be underlying this connection between mental disorders and inflammatory arthritis. And so what I decided to do for this particular paper that we're talking about is take a more granular level approach to characterize the relationship by specifically looking at individual healthcare visits and medications that are related to depression and anxiety, and look at them in the 5 years before the diagnosis of inflammatory arthritis, as well as the 5 years after, compared to people who don't have inflammatory arthritis. And this was all done under the hypothesis that depression and anxiety healthcare encounters would be elevated in this period of analysis relative to the comparators, but we didn't really know to what extent and how far this difference would exist from the diagnosis of inflammatory arthritis.
Yeah, really, really important question. Now, you used a large data set called Population Data BC, which I think is British Columbia, to do this work. Can you tell us more about the database? Whose data is in it and how can researchers access it?
Yes, so it is the Population Data BC is British Columbia, and this is the group who's responsible for managing and facilitating our access to this longitudinal individual level health services research data. And this is for the entire population of British Columbia. And so Population Data BC has data holdings from various sources. And specifically in this paper, a lot of the data sources are from the Ministry of Health in British Columbia. And essentially the data that we use captures nearly all medical services that are publicly funded for people living in British Columbia. And so this includes data holdings on outpatient visits. So when a person goes to see their family doctor or their rheumatologist, then that's recorded. It also includes information on inpatient visits or hospital visits, different demographics, and vital statistics. And so to access the data, Canadian researchers can submit a data access request to Population Data BC, and then they facilitate your access.
Do you have to be Canadian?
I believe so, but I'm not 100% certain. So I'm going to not know the answer. It used to be that it was only in British Columbia, and I'm not sure anymore if it's across Canada, but you definitely have to be Canadian.
Yes. So good reason to collaborate, I guess, encouraging collaboration across borders. So you also obtained prescription data, and that came from a database called PharmNet. Can you describe what PharmNet is and how does it interface with the Population Data BC database?
Sure. So PharmNet is the data that captures all the medication prescriptions that are dispensed in British Columbia pharmacies that in the outpatient setting. And so it has information on the type of medication, what date it was dispensed, the dosage, and so forth. And basically, PharmNet itself is one of those data holdings at Population Data BC, and its data source also is from the Ministry of Health. And so on the Population Data BC end, what they do is they can link these different data sets, so PharmNet and like the outpatient database, they can link them using personal health numbers of individuals. And then when that data is given to researchers, it's completely de-identified for research purposes. And so we just get, in the end, we get like a randomized number so that we can link people, but we have no identifying information about them.
Yeah, so that's really helpful and a crucial piece of this. How did you select your population of interest and then the control population? And over what time period did you study them?
So we wanted to identify individuals with incident rheumatoid arthritis, psoriatic arthritis, and ankylosing spondylitis. And to do that, we used case definitions that used ICD-9 or 10 codes in the outpatient or inpatient databases. And then our comparator group was individuals who did not have rheumatoid arthritis, psoriatic arthritis, or ankylosing spondylitis. And we matched them to our inflammatory arthritis group based on age and sex. And because we wanted to study mental health care encounters in the 5 years before the diagnosis of inflammatory arthritis, we had to restrict our time period a bit. And that's because the PharmaNet database itself, it doesn't begin until January 1996. So in order to have those 5 years before the inflammatory arthritis index date, our minimum inflammatory arthritis index date was January 2001. Mm-hmm. And then we followed individuals up until the data that we had, which was in March 2018.
And so how did you verify the coded data? Because we know that, ICD-9 and 10 codes are not perfect. Did you do any kind of verification?
What we ended up doing was using case definitions that were used within our research group before and ones that had been validated in the literature before. And so that's how we were identifying them.
Okay, so tell us now about the depression and anxiety coding. How did you assess that in this database, and what outcomes did you measure?
Well, we did use case definitions to identify the inflammatory arthritis group. We didn't do that when looking at depression and anxiety. And that's because I wanted to more look at the patterns of healthcare use for depression and anxiety in those annual increments in the 5 years before and the 5 years after diagnosis of inflammatory arthritis. So we looked specifically for ICD-9 and 10 codes for depression and anxiety that occurred in the outpatient and inpatient databases, and then also looked at prescription fills for antidepressants and anxiolytics within that PharmaNet database. And so with those codes, we essentially created binary variables that represented the proportion of individuals, so in the inflammatory arthritis group and the comparators. And we looked at what that variable was in each yearly interval in the 5 years before and after inflammatory arthritis diagnosis. And so what we looked for was the proportion with at least one depression healthcare encounter, at least one anxiety healthcare encounter, at least one antidepressant, or at least one anxiolytic. And I've tried to help people understand that methodology in figure 1 to really clarify how it was done. I know it was there was no case definition applied.
Yeah. And so do you want to walk us through figure 1? Because it is a nice way of kind of looking at that timeline. And this is obviously audio only. So if you can turn that into words for our listeners, that would be great.
Sure, I can try my best. So at the center of the figure here, we have the index date for inflammatory arthritis. And then we have the pre-diagnosis period. So those -1, 2, all the way to 5. And then we have the post-diagnosis period, 1 through 5. And so within each of those 1-year intervals, we looked at the proportion of individuals who had at least one depression, ICD-9 or 10 code in the inpatient or outpatient database. We then looked at individuals who had at least one anxiety, ICD-9 or 10 code in the inpatient or outpatient database. We then looked at the proportion with at least one antidepressant. And then we looked at the proportion with at least one anxiolytic. And that's within each of those 1-year intervals. So you can think of it as looking cross-sectionally within each of those intervals before and after diagnosis of inflammatory arthritis.
It was any of, right? Any of the 4. It didn't have to be all 4.
I looked at each 4 individually. So each of those is one outcome.
And then you also looked at some covariates and comorbidities. Can you tell us about those? And in particular, you used the Charlson-Romano Comorbidity Index. Do you mind telling us what that is?
Sure. So some of the covariates that we looked at were age, sex. We also looked at residence, so urban or rural. We also had a measure for neighborhood income quintile. And then the Charlson-Romano Comorbidity Index is essentially a weighted index that represents the presence or absence of several comorbid conditions. And this is done based on ICD-9 or 10 codes. And so with a higher score representing somebody with more comorbidities.
Yeah. Okay. So let's talk about your results. So you had more than 80,000 patients with incident inflammatory arthritis. What can you tell us about their demographics? What groups of arthritis did they have? Tell us a little bit about the population.
So we determined the demographics in the year prior to their index date. And so among those with inflammatory arthritis, the age on average was 56 years, and just over 60% of the population were females. And when we looked at the different types of inflammatory arthritis, about 3/4 of those had rheumatoid arthritis, about 12% had ankylosing spondylitis, and just over 11% had psoriatic arthritis.
Mm-hmm. And you have 3 other graphics in the manuscript. I'm wondering if you can walk us through them. So figure 2 comes first. Tell us a little bit about figure 2.
Sure. So for figure 2, there are 2 parts. There's panel A and there's panel B. And so I'll start with the first panel. So panel A shows the proportion of individuals with inflammatory arthritis and comparators who had at least one ICD code in the outpatient or inpatient setting for depression or anxiety. So we have depression here with blue, and then anxiety with red, and then all of the dashed lines refer to our corresponding comparator group. Mm-hmm. And so essentially what we see here is that over the 5 years before and the 5 years after diagnosis, the proportion of individuals with healthcare visits for depression and anxiety are consistently higher for individuals with inflammatory arthritis relative to their comparators. And this was especially noticeable for depression, where the proportion steadily increases until the year of diagnosis and then kind of plateaus. Panel B is similar to the one above, but we're now looking at prescription fills for antidepressants and anxiolytics. So antidepressants in blue, anxiolytics in red, and then the controls with the dashed line again. And again, what we see here is that there's a higher proportion of individuals with inflammatory arthritis who are prescribed at least one antidepressant and at least one anxiolytic relative to comparators throughout the pre and post-diagnosis period. And this was throughout the 5 years before and 5 years after diagnosis of inflammatory arthritis.
You also did some logistic regression analysis, and I actually really love how you visually represented that in figure 3. Would you mind walking us through that one and describe it for our listeners?
Of course. So figure 3, what I've done is it depicts the findings of the multivariable logistic regression for each of those 4 outcomes that we descriptively looked at in the previous figure. And so I ran these logistic regression models for each of those 4 outcomes within each year of observation. So the 5 years before and the 5 years after. And each panel here represents one of those 4 outcomes. And so as you can understand, there was a lot of results from running these regression analyses. We both the unadjusted and adjusted, which I really just put more in the supplementary material and wanted to graphically display as a figure using like a modified forest plot so that we can actually visualize how mental health care encounters varied over each year of observation before and after the diagnosis of inflammatory arthritis. And so what we kind of saw here is that individuals with inflammatory arthritis had significantly increased odds of healthcare encounters for depression, anxiety, as well as the dispensation of antidepressants and anxiolytics for each yearly interval through the 5 years pre-diagnosis and 5 years post-diagnosis relative to the comparators without inflammatory arthritis. And what you can kind of notice here in each of the panels is that those adjusted odds ratios were highest in the year immediately before or the year immediately after the diagnosis of inflammatory arthritis.
Yeah, really interesting data. And then I was very delighted to see that in figure 4, you drill down into the results based on sex. Did you see any differences between males and females in the cohort?
Yeah, so when we did stratify the analyses by sex, descriptively, we saw that it was a greater proportion of females having healthcare visits for depression and anxiety, as well as filling prescriptions for antidepressants and anxiolytics. And so these findings did reflect the descriptive epidemiology, with what we know about depression and anxiety. Although I will note that with these databases that we have in British Columbia, they're dependent on people accessing care to record those ICD codes or to fill a prescription, right? So I think we also have to keep in mind the differences in healthcare seeking behaviors between males and females and how that might also be reflected in the data.
Yeah, I'm going to turn that back on you because also there are differences in how men and women encounter the healthcare system, right? And, this kind of concept of the men tend to get aggressively investigated, the women get told it's all in their head and that they're just a little anxious, right?
Yeah. Yeah, and this will touch on some of my postdoc work too, because obviously this was an interesting aspect of my research during my PhD as well.
Yeah. So did you see any differences between the various types of inflammatory arthritis?
We did. So when we stratified by the types of inflammatory arthritis, and again, those were rheumatoid arthritis, ankylosing spondylitis, and psoriatic arthritis, descriptively, we observed some variability among the three types of inflammatory arthritis, and particularly that there was a greater proportion of individuals with ankylosing spondylitis who had healthcare visits and medications for depression and anxiety. And, we kind of thought about this in the discussion and thought that it could maybe reflect previous research that shows that the time from symptom onset to seeing a rheumatologist or to having a diagnosis was greatest for those with ankylosing spondylitis. So that could have been part of the results we saw when we stratified by the type of IA.
Yeah. Yeah, that's really interesting. And I'm going to let you speculate some more now. What do you think this data means? And then tell us a little bit about how you're taking this forward.
Sure. So when we saw that the healthcare encounters and medications were elevated in those 5 years before and after inflammatory arthritis diagnosis, it kind of allowed us to see more of that long-standing intrinsic link between these mental disorders and inflammatory arthritis, and to see that it's not just around the time of diagnosis. It's in the 5 years before and it's in the 5 years after. And so, more curious to explore how these shared biopsychosocial mechanisms underlying both inflammatory arthritis and mental disorders might be contributing to this relationship. So, for example, investigating the role of shared inflammation between inflammatory arthritis and depression could be an area of interest going forward, and a lot of people are interested in that. And then when I think about this work, I think it really brings up question as like, why is this happening? And when you have a question of why, it can often also be suited for qualitative inquiry. And so I think it would be helpful, when taking this forward, to interview people to understand, both to understand their perspectives on before they were diagnosed and after they were diagnosed, how their mental health was affected.
Yeah, and I do agree with you. I mean, I think it's really important to remember that the immune system goes everywhere.
It does, yeah.
And very often the biology is telling us something. We have to listen to it and help the science catch up.
Mm-hmm.
So now that we've discussed your data, I wanted to learn a little bit more about you and your journey in rheumatology. And we always love to hear about people's mentors. Yours was Dr. Mary de Vera, the senior author of this manuscript. Tell us what attracted you to working with her as you embarked on your PhD.
Sure. So it actually goes back to before my PhD. So I did my master's as well with Mary at the Faculty of Pharmaceutical Sciences at UBC. And it goes back even further than that. So I was working as a research assistant at BC Children's Hospital. And we had a mutual friend who, when I was trying to figure out what I wanted to do next after finishing my bachelor's and taking some time to work, I was talking to this mutual friend and she's like, oh, let me introduce you to Dr. Mary de Vera. And it turns out that Mary and I, at different points in time, but not had actually worked for the same surgeon at BC Children's Hospital. And so I was working on work that she had started, and then she had moved on to her PhD and working as an assistant professor. Yeah. So we didn't cross over, but yeah, like I would read her notes when I was doing work on like this RCT for the surgeon that I was working for. So yeah, I was introduced to her from my friend, and she, when I met her, she's obviously very successful in her field. Her research was in the area that I wanted to pursue, so epidemiology, health services research. And so what I did is because Mary was also going to be going on maternity leave, I worked with her part-time as a research coordinator before starting my master's. And I think what really attracted me to working with her is that she really cared about the development and success of her trainees and the people that she worked with. So you can see that as like a trainee by looking at, do they have their trainees on papers with them, on grants, how like their teaching style, and just the amount of detail that she gave back, detailed feedback that she gave back on the work, made it really evident that she cared about your growth and success.
Yeah, which brings me to my next question. You know, the relationship as mentor and mentee is always bi-directional. What comes first, a good mentor or a good mentee? And you share your tips on how you kind of built that relationship over time.
I really love what you do with that question, but it's hard. It's kind of hard to answer because I don't really know what came first here. I think maybe both. And I think I definitely grew into a better mentee, hopefully, with my time with Mary. As to what made our relationship successful, I think a lot of it is that we were both really excited about the research that we were doing and really motivated by it. And, we celebrated like those big wins. I remember getting like a CRHR grant that we'd worked on together and being super excited. But then also there's lots of setbacks and rejection in academia. We know this. But it was always like met with, okay, like let's get together, cultivate a plan to continue moving forward. And it was, we just like kept working and we're still excited to do the work that we were doing. And she somehow got me excited about writing grants, and I now love writing grants, which I didn't anticipate. But then I think what was also made our relationship successful and was more about she also let me explore research questions that were important to me and that I was interested in. So when I brought the idea of looking at mental health and inflammatory arthritis, her research was not focused on mental health, but she was very open to allowing me to like expand her research program and bring this in as my PhD project. And then I think like the biggest thing that helped this to be successful is that we both recognize that we all have a life outside of academia.
Mm-hmm.
We have periods of hardship, we have periods of change. I had a baby during the end of my PhD and went on maternity leave, and she supported me throughout all of that. And I never felt, the pressure to like come back and get back to work. I had the time to be with my daughter and then come back to work, finish and move on. And, you just recognize that there are, the life outside of academia is important and you need to have that balance. And so when you have somebody who recognizes this and provides support and vice versa too, right? Like I think I came at it from that point as well. And I think that was really critical to success, especially in academia.
Yeah, no, and it's a true partnership. But as with all good things, unfortunately, even PhD training must end. Can you share with us what you're doing now? And do you have any advice for people kind of coming to the end of PhDs and looking for the next position?
Yeah, so I think there are a few different approaches you can take when looking for a postdoc position, at least from my experience. So you can look for different positions. They're often posted. You can see and apply and do job talks and so forth. But I can speak more to the path that I took, which is I wanted to apply for a CIHR fellowship. So that's like the Canadian Institutes of Health Research. They have fellowships for postdoc training. And so to apply for one of those, you need to be thinking very far into the future, which I feel like I've had to do throughout all of my graduate training, when sometimes you just want to focus on right now, but you also have to think about, a few years down the line. And so to apply for that CIHR fellowship, you need to identify a supervisor earlier on during your PhD training and apply for that fellowship with that potential postdoc supervisor. And so that's the path that I took. And I think whatever path you decide to take, like applying for positions nearing the end of your postdoc or applying for those fellowships in advance, I think that networking is very important to identify postdoc positions, even if it's just exploring connections among your supervisors or committee members or different mentors within your faculty or university. I think that that's a really good place to start in identifying potential supervisors for your postdoc.
Yeah, and you actually decided to move internationally for your postdoc. So you're now at Stanford, correct? So
yes.
CIHR are supporting you overseas.
Yeah, they are. Yeah. Yeah.
So how does one do that? Do you have any advice for people looking internationally?
Internationally? I mean, it's a lot of work to move. For me, it's been worthwhile. It's been difficult when you have like a young family and a partner who has to switch jobs. But for me, I mean, it's been a really good move for us and the family. And yeah, I just think there's a lot of little pieces that you don't realize, like visas and
Mhm.
importing cars and banking. It's complicated, but it's doable. And just ask. I think I found it really helpful to talk to people who had done the international postdoc before to get a sense of how difficult the move was going to be. But yeah, I think
Yeah,
it's been
but it kind of gives you a well-rounded, very different as sort of viewpoint on life and science as well.
it does, yeah.
And are you allowed to tell us anything about what you're working on now?
I can give a preview. So what I'm working on now, and what's tied to my CITR fellowship is I'm working with Dr. Julia Simard at Stanford, and we're looking at biases in how biases in clinical decision making may contribute to the sex and gender differences observed in the diagnosis of various chronic diseases. And so for me, I'm looking at major depressive disorder. And then we're also working on a case with lupus. And then more broadly, what I'm working on now is developing skills to work with the many different administrative health databases that we have here in the US. So there's like
Mhm.
MarketScan, Medicaid, and in particular, I'm interested in studying postpartum depression among people with lupus.
Yeah, really important issue. And I'm excited to seeing some of those results come through to publication. I really want to thank you, Elisa, for joining us today. This has been an excellent discussion, and I really appreciate you sharing all your research and your experience as a PhD student and now a postdoc.
Yeah, thank you so much for having me. It's been a pleasure chatting with you.
And today's thanks also goes to everyone who asks what came first. It's a fundamental question that we should ask more often. Thank you all for listening to this podcast. ACR Journals on Air is a production of the American College of Rheumatology. Please follow at ACRheum on social media. Email us at podcast@rheumatology.org and rate and subscribe to our podcast at acrjournalsonair.org or wherever you get your podcasts.